First of all, first group of diseases is obstructive lung diseases. What are they? Obstructive lung diseases. Now, obstructive lung diseases are those lung diseases in which there is increased resistance to the airflow through the air passages. Obstructive lung diseases that when air is moving through the air passages, there is increased resistance. There is some degree of pathological obstruction faced by the air to flow through airways during inspiration and expiration. Is that right? Then we call, now if this kind of obstruction is there in the airways, we call it obstructive lung disease. Right? Usually, generally speaking, obstruction is more pronounced during expiration and less pronounced during inspiration. In obstructive lung diseases, during inspiration, degree of obstruction is less, and during expiration, degree of obstruction is more. What I am trying to say, that generally speaking, in obstructive lung diseases, for air to enter in is relatively easy, but to get out is relatively more difficult. I mean, this is something that you can get in, but you cannot get out. There are many situations in life like that. You get into a relationship sometimes, but you cannot get out. Or there's more resistance. You happily entered in inspiration, but to get out of the relationship, sometimes there is unusual obstruction. Now, question is, before I go into really detail and all these causes, I must explain why in obstructive lung diseases there is more resistance to the airflow during expiration and why there is less resistance during inspiration. To explain that, I will go to normal lung, how the normal lungs behave, right? During inspiration and expiration, right? Let's suppose this is your normal lung, healthy lung, alhamdulillah, and these are the airways, right? Okay, I will make these black. These are distal air spaces, right? These are all air spaces. And they are all around. Is that right? Yes. This is lung parenchyma. Now, as I told you previously, that lungs have a lot of elastic tissue. So they love to recoil. Lungs normally love to recoil. But normally in a healthy person, lungs are kept inflated due to negative intrapleural pressure. Is that right? Now imagine, this is your pleural which layer? And this is parietal. When chest wall is expanding, during inspiration, chest wall is pulling the visceral layer outward, that is pulling the lung outward. In the same way diaphragm. So what happens, that lung is, during inspiration, lungs are being pulled from everywhere outward for expansion. Lungs are being pulled outward. When they are being pulled outward, this airway, suppose this airway, lung is being pulled there and pulled here. What will happen to this airway? Open. So during inspiration, what happens? When whole lung is expanding, there is a peripheral traction of the elastic lung tissue on the airways as well. And airways are also expanded, right? Let me make a section from here, this airway. Right? If I make a section here, this airway I put, this is the airway, this point, right? and this point. This is the airway, and here are, what are these? Your lungs, different spaces. Is that right? Now during inspiration, now listen carefully. During inspiration, when lung is expanding, you are understanding? When it is expanding, there is traction on what? Airway, right? Or we can make a part of a lung like that. I make a section of lung here. This is airway, right? And then it is dividing into, let's suppose, air spaces, right? Now actually, all this is surrounding by lung parenchyma. You understand it? When lungs are expanding, it means the whole lung parenchyma is expanding. Lung whole parenchyma. So this, all the lung parenchyma which is surrounding what? This airway, that is also pulling the airway outward, all walls. So airway will become open. This is what happens normally during inspiration. There is that during inspiration, to already open airways, there is, as lungs are expanding, elastic pull of the lung tissue has added traction, radial traction on the airways. So during inspiration, they become more wide open, and inspiration is relatively easy. Now, in a healthy person first, during expiration, what happens? In a healthy person, when expiration is occurring, lung is getting smaller. When lungs are getting smaller, the traction on the airways by the pulmonary substance is increased or decreased? Decreased. When traction is decreased, they become relatively smaller. So in a normal healthy person, during inspiration, airways are relatively wide, more open, and in a normal healthy person, during expiration, airways are relatively narrow. But this little narrowness does not produce any pathology in a healthy person. Is that right? Now you imagine, if there is some obstructive disease, let's suppose there is some obstructive disease, and due to that reason, there is some obstruction here. So airways permanently smaller. Now during inspiration, airway will still open due to traction around it. But during expiration, it may become very, very narrow. You are understanding? Again, I will repeat. If there is obstructive airway disease, let's suppose there is some obstruction to this point, right? Now, okay, leave a little opening at least. Now there's a little opening here. When this person will do inspiration, as lung tissue will expand, it will radially open the airways. So during inspiration, it open a little more, and there is less resistance to the airflow. There is resistance, but less. But when this person do expiration, when lungs are getting smaller, airways are no more pulled radially outward, so they also become further small. And because there was pre-existing obstruction at the top, during expiration, the airways become smaller. So for outward flow become too much restricted. Are you understanding?
Yes.
Or I'm just teaching myself? You got it? So I will repeat what I said up to now. First of all, I said airways are not static, they are dynamic. During inspiration, they open, and during expiration, they become little narrow. In a healthy person, during inspiration and expiration, in both situations, in a healthy person, airways are open. But they are more open during inspiration and less open during expiration. Why normally they more open during inspiration? Due to radial traction of elastic tissue. When lungs are expanding, all the airways open. And during expiration, when traction on the airways from the periphery is less, so elastic recoil of airway wall little bit narrow the airways. Is that right? Then I came to this thing. If in the airway there is already obstruction, if there's some obstructive disease, right? If there is some obstructive disease, that during inspiration, airway may open a little bit, and inspiration may lead to some inflow of the air. But during expiration, airway become pathologically too much narrow, and there's more difficulty in getting the air out. Again, in obstructive lung diseases, obstruction during inspiration is less pronounced, and during expiration it is more pronounced. So usually in obstructive lung diseases, the main problem is not how to get the air in. The more serious problem is usually with exceptions, usually how to get air out. It means during inspiration you take the air in, and during expiration less air come out. During inspiration you take more air in, during expiration you take less air out. Progressively you accumulate the air and lungs become bigger and chest become barrel shaped in obstructive lung diseases. Any question up to this? No. Here I want to tell another thing. Okay, come over here. What are obstructive lung diseases? Who will tell me? Okay, doctor. Just name the obstructive lung diseases. You are about to impress me. Yes, please. Emphysema, very good. Emphysema. This produces obstruction. I will explain how. Then there is chronic. Very good. Bronchitis. Then asthma. Then bronchiectasis. Now these are common obstructive lung diseases, right? There are some other also. I will not go into detail of those. Now, obstructive lung diseases, the lung diseases in which there is obstruction to the airflow, especially more pronounced during expiration, is seen in patient with emphysema, patient with chronic bronchitis, patient with asthma, and patient with bronchiectasis, right? And there is a term very commonly used, chronic COPD. Have you heard of this? There is a term called COPD, chronic obstructive pulmonary diseases. Very good. What is the difference in obstructive lung diseases and COPD? Question goes to any young man. Raise your hand. Who can tell me? The difference between obstructive lung diseases and COPD. It means I'm asking about what is the difference between obstructive lung diseases and chronic obstructive pulmonary diseases. Yeah. Yes, he is saying it's the same. And all of you must know he is wrong. He is wrong. All obstructive lung diseases are not the part of COPD. This is very important to understand. Many doctors get confused about it. There are so many diseases which produce obstruction to the airflow in the lung, but all of them are not COPD. All of them are not chronic obstructive pulmonary diseases. When we talk about chronic obstructive pulmonary diseases, basically we are talking about these two. Classically speaking, typically speaking, these two are COPD. So I can classify it like this also. Obstructive lung diseases are COPD, asthma, and bronchiectasis. Another better way for understanding, obstructive lung diseases are COPDs, asthma, bronchiectasis. And COPD mainly include emphysema and chronic bronchitis. Is that right? And all these diseases, because they produce some degree of obstruction, right? Because they are producing some degree of obstruction, what happens? During inspiration, let's suppose, okay, we talk about this situation. There's obstruction here, right? Obstruction. Now, in these cases, air will, during inspiration, will get into airways and air spaces, right? Air will enter. But during expiration, all of it is not going out. So pressure in the alveoli will go up or down? It will be up. It's very simple. That when there are obstructive lung diseases, regardless of its emphysema or chronic bronchitis or asthma or bronchiectasis, whatever kind of obstructive lung diseases, right? because there is more obstruction during expiration, so air is trapped here. Air is trapped here, but wall of alveoli, now pressure in the alveolar space is increasing, right? In obstructive lung diseases, when air traps and pressure in these air pockets increases, when pressure in these air pockets increases, alveoli are very delicate walls. They may rupture. They may rupture. And if they rupture just under the pleura, then there will be direct entry of air into pleura. Now you understand how a patient with obstructive lung disease has predisposition for pneumothorax. Why? Because these patients have, number one, higher pressure in alveoli, and some of the alveoli really become high pressured in obstructive lung diseases, and their delicate walls of the alveoli may rupture. And if it is just subpleurally, air will escape into pleura and produce pneumothorax. Or alveolar rupture, where? In the interstitium, delicate walls. When alveolar rupture, air which was under pressure will enter into interstitium, and this interstitial air will track, as I mentioned previously, and eventually enter into pleural cavity. So either there is subpleural leakage of air from the alveolar spaces, or there is interstitial leakage of alveolar air, right? And then interstitial area is dissected by the air, and this dissection may move proximally towards the mediastinum, as I mentioned previously, and eventually it may rupture the pleura and produce pneumothorax. So is it clear that how obstructive lung diseases can predispose a person to pneumothorax? This pneumothorax may occur without trauma. There is no one is putting the knife in your chest. There is already pathology in the lung, and that pathology precipitated this secondary spontaneous pneumothorax. Am I clear?
Yes,
Anyone who is confused? Very good. Here I want to mention one thing. When we talk about that airway obstruction, especially airway obstruction, it's very clear. In chronic bronchitis, underlying pathology is that airway has hyperplasia of mucus glands in chronic obstruction, and there are more secretions. Again, I will repeat. Let's suppose here you have airway cross section, right? These are the mucus. What are these? Mucus glands, right? These are the blood vessels, right? And here are what is this? Smooth muscles. What are these? Smooth muscles. Now this is the lumen. What is this? This is the lumen. Now imagine, I will talk about emphysema later. In chronic bronchitis, what is the underlying problem? Even though it is diagnosed clinically that there is persistent cough more than 3 months with sputum production, may or may not be, but with sputum production more than 3 months in 2 consecutive years without any other explanation of the clinical features, right? But I will not go into detail. We will have a full lecture on chronic bronchitis, thorough detail. For a while I will just mention in chronic bronchitis what really happens, that these secretory glands become hyperplastic and there are more secretions, and if they are producing more secretions, it means there is intraluminal obstruction in chronic bronchitis due to increased secretion. Plus in chronic bronchitis there is inflammation of bronchial wall, and this swells inward. When it swells inward, further reduces the lumen. So in chronic bronchitis, obstruction is due to luminal increased secretions and also due to inflammation of airway walls, bronchial walls. Clear? In asthma, what happens? There are 3 components. 1, increased secretions. Number 2, inflammation of the wall and swelling and edema, plus constriction of bronchoconstriction, episodic reversible bronchoconstriction. All these things can lead to obstruction. So this can lead to obstructive situation. This can lead to obstructive situation. Later on, we'll discuss in detail in bronchiectasis what happens. They are necrotizing inflammations, necrotizing inflammation of the wall of, what is this? Bronchi, which lead to destruction of cartilages and smooth muscles and other components of the bronchial wall. And at places, bronchial walls pathologically and irreversibly dilate. But because they have increased secretions also, let me make airway with bronchiectasis. This is airway. It has one pocket here and one pocket here and one pocket here, like that. Now what happens in this area, there was necrotizing inflammation which destroyed the elastic tissue and sportive component of the bronchial wall so much that it becomes very weak, and due to air pressure it bulge out. So these are, you can say, permanently irreversibly dilated areas of airway. This is bronchiectasis. But you need to remember that inflammation is not only in these pockets. Inflammation is in between that too. You are understanding? So whole lining of bronchial tree is inflamed in bronchiectasis. Multiple areas are inflamed, and if this area is inflamed and there is infection and secretions, it will become obstructed. So what I'm saying, that chronic bronchitis, it leads to what? Obstruction due to increased secretions and inflammation and edema of airway walls. Asthma, obstruction due to increased secretions, swelling and edema, inflammation and bronchoconstriction, smooth muscle restriction, and bronchiectasis also has obstruction due to increased secretions and inflammations. Is that right? The real master understanding is needed to understand why in emphysema airways become obstructed. Because emphysema is a disease related with distal air spaces. Emphysema is a disease related with distal air spaces. So what really happens in emphysema, that air spaces become enlarged, alveolar air spaces become enlarged, and their septa are destroyed. This is the basic pathology, right? Again, let me explain. This is, let's suppose, I'm just showing part of a lung which is having emphysema. Now, what is happening? These are the normal Now you see, what is happening? Actually, in emphysema, these septa, these are destroyed, right? Due to inflammation. We'll have a full lecture on emphysema. For a while, you just trust me. That what really happens in emphysema, these septa, these are destroyed by different proteolytic enzymes and collagenases and elastases which are released by neutrophils and other mechanisms. When they are destroyed, what will happen? That it will become like that. I mean, air space will become like this, and this component is lost. Here also, if air space was like that, this component is destroyed. Intraalveolar septa are destroyed, and if they are destroyed, then it will also become like this. Here also they are destroyed, become like that. So what really happens in emphysema? That interalveolar septa are destroyed, and when they are digested away and destroyed, distal air spaces will become smaller or larger? Of course larger, right? But these septa have elastic tissue. It means if there is widespread emphysema of the whole lung, if both lungs undergo widespread emphysema, it means millions and millions of intraalveolar septa are destroyed. Millions and millions of interalveolar septa are destroyed. If they are destroyed, it means actually lung elastic tissue is destroyed. What does it mean? Lungs elastic tissue is destroyed. And when lungs elastic tissue become destroyed, lungs become tight or they become loose. Okay, just imagine you have a rubber band. And in a rubber band, if elastic tissue is destroyed, then it will recoil strongly or it will recoil weakly? It will recoil weakly. Are you understanding what I'm saying? That again, in the lungs, elastic tissue is destroyed because interalveolar septa are destroyed. So lungs' tendency to collapse is less or more? Less. What really happens? Air spaces become large. Okay, I will show you here also emphysematous changes. So this also become like this, this and this. Septa are lost. Now you imagine that if this is the airway, around it there are all air spaces. If all air spaces have lost their septa, then their ability to keep the airway open, radial pull, is increased or decreased? Decreased. This is what happens in emphysema. That in patients with emphysema, even though patient with pure emphysema, there may not be pathology, significant pathology in the airway itself. Pathology is in the alveolar area. But due to loss of interalveolar septa, or we can say due to loss of elastic tissue in the lungs, the radial traction on the airway is reduced. So patient with emphysema lungs have big lungs but narrow airways. Are you understanding? Yes. They have big lungs, overinflated lungs, hyperinflated lungs, dilated air spaces, but because airways cannot be having a traction outward, so what really happens that this elastic tissue, which was previously very tight, now it becomes loose because there is less elastic tissue, so it cannot keep it open. So during inspiration, air may go somewhat, but during expiration, it can come out easily? No. So this is a mechanism of obstruction in patient with emphysema. So if someone asks you in emphysema, in patient with pure emphysema, because many patients have a combination of features of emphysema and chronic bronchitis, because both of them are associated with smoking, strongly associated with smoking. But if you end up with a patient with emphysema, pure emphysema, then what will happen? That distal airways, distal air spaces or interalveolar septa are destroyed. It means collagenesis and elastases have been very active, and when elastic tissue of the lung is destroyed, lungs have less tendency to recoil, and even even the normal radial traction on the airways by the surrounding lung tissue, that is also reduced. So airways become narrow. So during inspiration, there is resistance to the flow but less, but during expiration, there is pronounced obstruction. Right? You are understanding? And you are understanding it or not? Clear? Okay. Any question up to this? Right? So these are obstructive lung diseases like emphysema, chronic bronchitis, asthma, bronchiectasis, and other obstructive lung diseases. They can lead to emphysema, can lead to pneumothorax, either by release of air directly from subpleural rupture of the alveoli, or rupture of alveoli due to high pressure in interstitium, and then air moves through the interstitium into the mediastinum, and then it may rupture. Any question up to this? So now you are very clear, hopefully, that patient who have obstructive lung diseases, right, they have a higher risk of pneumothorax, spontaneous pneumothorax, and this spontaneous pneumothorax must be considered secondary pneumothorax.